Good morning, everyone. Today's my topic is retrofixated iris claw lens implantation and its results in tertiary care center. As we know that complicated cataract surgery is most common cause of aphakia. Zonular dialysis and the posterior capsular tear and dehiscence can cause inadequate capsular support and difficulty to implant the in-bag IOL and ciliary sulcus supported IOLs. Angle supported anterior chamber intraocular lenses and iris claw lenses, retrofixated IOLs and sclerofixated IOLs. There are various options which are available for the surgical correction of aphakia. ACIOL insertion is technically easy, but it can carry very complications such as pseudoficibulous keratopathy, uveitis, damage to the anterior angle, structures and the glaucoma, cystoid macular edema, pupillary block, fibrosis of haptics. Anterior chamber iris claw, they also carry complications such as corneal endothelial damage, secondary glaucoma, and pupillary block. SIFILs, they are also available, but they had a difficult procedure for fixation. Retropupillary iris fixated IOLs, very simple, effective, and safer technique for ACIOLs and anterior iris chamber claw lenses. And this is our video. This is. Let's start with the video. This is a patient of aphakia. Under all aseptic condition, we make 2 paracenteses at 3 o'clock and 9 o'clock position. If required, make sure that there should be no remnant of capsule in there. If required, anterior vitrectomy is done. And then we use the keratome for the main port, and with the extension blade, the main port is extended. We use a special kind of iris claw holding forceps in this, and with the help of iris claw forceps, we insert the iris claw at 12 o'clock position and from our main port. We insert into the anterior chamber and turned it horizontally with the help of Sinskey hook. Just catching hold of iris claw in the center and then just pushing gently below the iris structure with the help of Sinskey hook. We tug in the iris structure from one side, and with the minimum manipulation, we'll try to push this just behind the iris structure and then tug it with the help of Sinskey hook. Make sure that the 2 dimples will arise on the peripheral iris, making affirmation that this is centrally placed. After removing the viscoelastic and clearing the AC chamber, we put a suture on main port, and peripheral iridectomy is done before that. And the ports, they were hydrated. Our next video is also of aphakia patient, and 2 ports of paracentesis at 3 and 9 o'clock were done, and main port was extended with extended blade, and then we insert the iris claw with a special kind of iris holding forceps that is artisan, easily available. Make sure before inserting the iris claw that the haptics should be separated from each other, and then we insert it into the anterior chamber, maintaining the AC with viscoelastic. Just turn it horizontally with Sinskey hook very gently, push the one haptic under the iris and other haptic with minimum manipulation into the second iris structure. Just tug in the iris structure with the help of Sinskey hook and placing the optic in the center, removing the viscoelastic, and then we close the main port with suture 10-0 and hydrate the ports. And after doing the peripheral iridectomy, just to prevent the pupillary block. So my aim of the study was to analyze the implementation of to correction of aphakia both as primary and secondary procedure. This was study done at Regional Institute of Ophthalmology in Amritsar, and the data was obtained as timing of surgery, under corrector visual acuity, best corrector visual acuity, signs of endothelial cell loss, conditions of iris, IOL positioning, IOP, pigment dispersion, gonioscoping, and other complications. And 30 patients were taken, in which 18 were considered as a primary lens procedure and 12 were considered with the secondary lens procedure. The cause of aphakia on these patients were intraoperative complication, they were 25 in number, and 3 with subluxated mature lens and 2 with traumatic cataract. The postoperatively, the visual acuity were, 20 of the cases were seen by 6.6 and 6.18, 5 were seen 6.12, and 5 were seen with less than 6.60. The 12 eyes, they have significant ovalization of pupil postoperatively, 3 eyes with the CME and 1 eye with retinal attachment, 2 with iris atrophy, and 1 with poor pupillary dilatation. The main pupillary distortion was the most common complication noted in 12 patients, which was followed by pigment clumping in 1. Elevated IOP were seen in 3 patients and 2 have iris chafing. Aphakia is one of the most common complications in cataract surgery due to inadequate posterior capsular support. So the placement of the iris claw has advantage of posterior iris chamber with less intraoperative complication and best possible rehabilitations. So in conclusion, this is the safest and effective method to correct aphakia in the patients with no posterior capsular support. Thank you very much.
Next speaker, please.
Harpreet.